Hi, as you heard, my name is Marta Boffito, and I'm going to talk about the use of integrase inhibitors in patients with comorbidities and polypharmacy. These are my disclosures. I'm going to just kind of introduce the topic and share with you why we're talking about this. And then we're going to look at pharmacology and adverse events of integrase inhibitors. And at the end, we're going to briefly going through a case study. So I'm sure you're all aware that the incidence of comorbidities is higher in people living with HIV compared to people without HIV. And this is especially true in people who are aging with HIV. As you can see from the results of the age HIV study from the Netherlands, when people age with HIV infection, they may experience a higher number of comorbidities than people without. And importantly, the JEPO cohort study that is running in Italy has also shown that older people living with HIV are affected by a higher prevalence of multimorbidity and a higher prevalence of polypharmacy when they have been affected by HIV for the longest, for 20 years or more. So polypharmacy is a very important concept within the HIV treatment scenarios. And it has been variously defined in the literature, but it is defined as the concomitant intake of 5 or more drugs. And this is important because when people take 5 or more drugs, they are at a higher risk of occurrence of drug-related problems such as toxicity or drug-drug interactions. And this, of course, can have detrimental health outcomes. The prevalence of polypharmacy in people living with HIV above the age of 50 has been reported by numerous studies in many different countries like Italy, Spain, France, and so on. And as you can see illustrated in these slides, a lot of these studies reported a high prevalence of polypharmacy. So a lot of people aging with HIV are on many drugs, definitely more than 5. In the UK and Ireland, there is a study called POPPY, which looks at several aspects of aging with the HIV. We have conducted an analysis looking at the rates of polypharmacy and comparing this in people who are aging with and without HIV, and in younger people with HIV. And we saw that all the people living with HIV are not at a higher risk of drug-drug interactions between antiretrovirals and non-antiretrovirals because they're on polypharmacy, but they're also at the higher rate at a higher risk of drug-drug interactions between non-antiretrovirals and non-antiretrovirals, because again, they are on important polypharmacy. Also, at Chelsea Westminster Hospital, where I work, we have a clinic dedicated to people aging with HIV, and we have looked at the anticholinergic risk in our cohort of elderly people, and we have seen that it is really important to review the anticholinergic risk due to certain medications and frequently polypharmacy in people on antiretrovirals. And this has been shown to be especially true in people on boosted antiretrovirals like elvitegravir, cobicistar, or boosted protease inhibitors. Obviously, the anticholinergic risk is something really important in people aging that we need to review to avoid increased risk of falls, confusion, and neurocognitive deterioration. So let's have a look at what advances the unboosted integrase inhibitors has brought following the introduction in clinical practice. This slide shows a table looking at the potential for drug-drug interactions of different antiretroviral drugs. And you can see that drugs like bictegravir, raltegravir, and dolutegravir are characterized by a moderate to low potential for drug-drug interactions. And this is obviously really important in people who are on polypharmacy. The reason why dolutegravir is characterized by a mainly low, but kindly a bit more towards moderate than other very low potential drug interaction drugs is because it is a perpetrator of a drug-drug interaction at the level of the kidney. Dolutegravir is an inhibitor on an influx transporter called OAT2, and this may lead to an increase of the concentrations of metformin in plasma. This is quite important because metformin is used for the treatment of diabetes, and I'm sure you're aware, people living with HIV, aging with HIV, are at a higher risk of developing diabetes than people without HIV. So metformin is a very commonly used co-medications in our clinics. Do we worry about these interactions? Well, actually, in people without renal impairment on metformin doses such as 500 milligrams twice a day, we have extensive experience of co-administering dolutegravir with metformin, and we haven't seen any side effects. And we also have experience in people taking higher doses of metformin. And only one case in the literature actually has been reported, one case of lactoacidosis. I think the most important thing when we think about this drug-drug interaction is obviously to see whether metformin works, but also whether the patient is at risk of renal impairment. That will contribute to increase the risk of side effects of metformin. Now, if we look at the clinical pharmacology profile of integrase inhibitors, again, while focusing on the unboosted one, dolutegravir, raltegravir, and bictegravir, we can see that dolutegravir and raltegravir are mainly metabolized by UGT1A1, and bictegravir is half and half metabolized by cytochrome P453A4 and UGT1A1. So the important thing, though, is that they are not perpetrators of drug-drug interactions, with the exception of the one that I just described for dolutegravir, which has a limited clinical significance. However, obviously, when we talk about drugs, we must not forget about adverse events. And there is a lot of talking about integrase inhibitors and adverse events. We know that some studies have reported central nervous system adverse events in a minority of people taking dolutegravir, but the really hot topic at the moment is weight gain and metabolic syndrome. And this is because studies from around the world, such as the ADVANCE study, have shown that antiretroviral naive patients starting TAF-FTC dolutegravir or TDF-FTC dolutegravir have shown remarkable weight gain compared to people starting tenofovir FTC efavirenz. And this was especially true in the presence of TAF when combined to dolutegravir, and also especially true in women, as you can see illustrated in the graphs. Furthermore, a multivariate analysis of weight gain following antiretroviral initiation authored by Paul Sachs and colleagues showed that integrase inhibitors are the class that is mostly associated to weight gain following the initiation of treatment. This was especially true for bictegravir and dolutegravir, and we will look at NRTI use. This was especially true for TAF. Now, the scenario in terms of weight gain is a little bit different for antiretroviral combination switch. So we mentioned antiretroviral combination initiation. We need to remember that in the case of an antiretroviral naive person that starts treatment, we have the return to health effect. However, in the context of switch, the weight change in the studies is less remarkable because it removes the return to health phenomenon. We have seen a role of switching from TDF and efavirenz to other regimens, suggesting that TDF and efavirenz may contain weight changes, and that's why when we stop them and switch to something else, people living with HIV may gain weight. The rate of weight gain, for example, switching to dolutegravir and lamivudine, doesn't seem to appear to be remarkable, again, in people who are already on antiretroviral therapy, unless they switch from TDF and efavirenz. That is when the weight gain is more important than switching from other combinations. I think that we need more prospective clinical trials to investigate these issues further. There is a meta-analysis actually also published that looks at weight change following antiretroviral therapy switch, that looks at different combinations and again shows for some combinations limited weight gain, but a very different scenario than what we saw for antiretroviral naive patients. Now, this is very important, not just because of weight gain, but because weight gain is associated to the metabolic syndrome. And the metabolic syndrome involves visceral adiposity, insulin resistance, increased triglycerides, low HDL, hypertension, and it is really important in the population. This has been seen in people with and without HIV because of the increased risk of accelerated atherosclerosis, cardiovascular disease, type 2 diabetes, gout, chronic kidney disease, obstructive respiratory syndrome, non-alcoholic fatty liver disease, certain cancer, pro-inflammatory state, pro-thrombotic states, and premature death. So it is quite important that we really understand the role of certain antiretrovirals in the development of weight gain and metabolic syndrome. However, I think it is important to underline that drugs are always associated to potential limitations, and the integrase inhibitors, the unboosted integrase inhibitors, brought remarkable advances to HIV clinical practice. To conclude, I would just like to show you a very complex case of an individual which is aging with HIV and is currently on TAF, FTC, and raltegravir 400 milligrams twice a day. So he's actually 39 years old and has been HIV positive since 2004. His baseline resistant test is wild type, his viral load is undetectable, and his CD4 count is 310. So this seems quite simple, actually, from a treatment point of view. But when we look at his comorbidities and comedications, we see that these are extensive. And I'm sure you're aware, we see this in clinical practice quite a lot. This gentleman presents with obesity, insulin resistance, asthma, COPD, depression, neuropathic pain, heartburn, hypertension, and osteopenia. And he is on a waiting list for bariatric surgery. He's on a diet. He's on salmeterol and fluticasone inhaler. He's on mirtazapine for his mental health, gabapentin, omeprazole, and ramipril. So he's definitely on polypharmacy. He's probably on important polypharmacy because he's on more than 10 co-medications. And his antiretroviral history is quite complex because he has an extensive history of not tolerating different antiretrovirals. He never really failed to date, but he couldn't tolerate efavirenz, atazanavir, ritonavir, darunavir, ritonavir. So he was prescribed raltegravir twice a day, but then simplified to dolutegravir, but couldn't tolerate dolutegravir. So he was switched back to raltegravir twice a day with TAF because of osteoporosis. So as I said, he's on the waiting list of bariatric surgery, and it is important to remember that there are some guidelines in terms of micronutrient replacement for patients undergoing bariatric surgeries, and that tell us that supplements, including iron, calcium, zinc, copper, and selenium, need to be taken up to 4 times a day for weeks before and after bariatric surgery. So we're all aware about the drug interaction between integrase inhibitors and some minerals. And if he is on raltegravir twice a day, it might be difficult separating the replacement therapy with the integrase inhibitors. So there is a potential for a drug-drug interaction there. Also, because of his asthma, he's on fluticasone inhaler, so it is really important to avoid the booster. So he definitely needs an unboosted integrase inhibitor as a third agent. This table shows you the potential drug interactions risk between steroids and boosters. He's also experiencing neuropathic pain, but he doesn't respond to gabapentin, and his a neurologist would like to try carbamazepine. Carbamazepine, however, is an important inducer of UGT1A1 and cytochrome P453A4. So although it's not completely contraindicated together with raltegravir, we might want to watch that doesn't decrease raltegravir concentrations too much, as this would lead to the risk of virological failure. So this is another drug interactions that we need to keep an eye on, especially because it can't tolerate numerous third agents. So we need to make sure that we can continue what he tolerates. In terms of his heartburn, he's taking omeprazole. However, apparently he also takes antacids because he frequently forgets his omeprazole. And again, I'm sure you're aware about the drug interactions between cation-containing antacids and all the integrase inhibitors, including raltegravir. At the moment, he is on raltegravir 400 twice a day. And each different integrase inhibitors has a slightly different recommendation in terms of intake together with antacids of certain minerals. So in conclusion, I think polypharmacy definitely increases the risk of drug-drug interactions, as you've seen in other numerous patients. Drug-related side effects and medications errors are also increased when people are on polypharmacy. And antiretrovirals characterized by a low potential for drug-drug interactions have definitely a benefit in this population. Elderly patients are particularly at risk of polypharmacy and therefore drug interactions because of polymorbidities, as we've seen. However, every drug is characterized by side effects, and we need to be quite knowledgeable about it and quite open with the patients we see in clinic and discuss what the potential side effects could be. And this is obviously very true for integrase inhibitors, and weight gain discussions with patients is very important. And however, again, as I mentioned earlier, I think we need to underline the benefits that integrase inhibitors have provided to HIV treatment in aging people living with HIV, because no drug is perfect. However, having very potent unboosted drugs that are very rarely or non-perpetrator of drug-drug interactions is a great step towards optimization of HIV treatment. Thank you very much for your attention.